Go ahead. Okay.
Good morning, everyone. So, I'll be presenting on palliative and end of life care today. The contents of the presentation are as follows. Let's talk about epidemiology. To begin with, we must know the causes of death that could keep a patient in hospice or palliative care. From 1900s to 1980 to 2014, there has been a significant shift in epidemiology of death, particularly in the causes of death. It is better represented on this chart here. So, as you can see, the yellow line is for cancer. In the 1900s, the cancer patients, the death caused by cancer was significantly lower than it is right now. Even though the cardiovascular diseases took a rise in the 1980s, they're almost at, at the neck with cancer. This does not mean that cancer is the only disease that requires hospice or palliative care, but this trend reflects in the cost of illness. Most of the healthcare spending, which is 84% in the United States, goes to the patients with chronic illnesses. And cancer has served as a paradigm for end of life care, but it is not the only type of illness with a predictable terminal phase. Now, the other common illnesses that have a recognizable terminal phase include heart failure, chronic obstructive pulmonary disease, chronic liver failure, dementia. There are a lot of neurological diseases that can use hospice and palliative care, some like ALS, MS, Alzheimer's disease. Therefore, end of life care should be a part of all medical specialties and not only thought about with cancer. Let's talk about the site of death. Over the last 4 decades, there has been a steady shift in the preferred site of death from hospitals to their own homes, as listed by patients and their family members. Today, only 20% of cancer patients die in the hospital, and this number, in comparison to 70% in 1980s, is a pretty steep decline. Along the decline in number of deaths in hospitals, there has been a steady increase in the use of hospice care. Let's talk about the framework that hospice and palliative care uses. So, this is a very important diagram. As you can see, the first or the A diagram shows dichotomous model of healthcare. It was previously believed that as a disease progresses, life prolonging care is separated from palliative or hospice care. You see, there's no integration of these to life prolonging or palliative care. But now, the model that we use currently is the integrated model of healthcare, and that involves disease modifying therapy alongside palliative care and then progression to hospice. This is a simple line diagram that I drew, and to simplify this, as you can see that the palliative care is provided a few months prior to shifting the patient into hospice care, and hospice starts about 6 months before the uh, death is anticipated. And it does not stop with death. You need to provide support to the family members for bereavement and grief. Now, palliative care is not based on the patient's prognosis, it's based on the needs of the patient, and it can be given at any age. That is, children who are suffering from some terminal illnesses like cystic fibrosis, and the old and in the old age, and at any stage. You do not have to be of a metastatic cancer stage or the advanced stage to have palliative care. This uh, this paradigm provides a easy shift from palliative to hospice care and makes the transition easier for patients and the family and caregivers. And It is to be noted that palliative care can be provided along with curative treatment. It is not a separate entity. Now, who gets palliative and hospice care? This question is not very straightforward and does not have a straightforward answer because it is based upon four pillars of medical ethics. You cannot have a very quantitative approach to this. The four pillars are autonomy, which is the centerpiece of provision of care. The patient's needs are put before any other factor. Second is beneficence. Every decision made by the healthcare providers should have an expected positive impact on patient's condition. That is, the physician acts in the best interest of the patient. Third is non maleficence. That is, the physician must not do harm. And fourth is justice, which is equitable use of health resources. Now, even though we have the physicians decide very qualitatively and it's an individualistic decision based on patient's own wishes and the physician's idea of palliation, but there are some assessments that can be used to aid this decision making. One such example is this criteria, which has primary and secondary criteria as a part of it. I will not go in detail for this. Now, there are four broad domains in the framework involved in caring for patients in hospice and palliation. You must address physical symptoms, psychological symptoms, social needs, which includes interpersonal relationships, caregiving, and economic concerns, and existential or spiritual needs of the patient. Let's move on to assessment and care planning in case of palliation and hospice. The first step is to complete a comprehensive assessment of the patient. This includes history and physical examination, emphasizing on both physical and not forgetting the mental symptoms. And then elucidate the symptoms, find out sources of suffering, and how much these symptoms interfere with the patient's quality of life. There are some standardized tests that are used to assess these, and they can be frequently used over fixed duration of time uh, and periodically to assess the effectiveness of the interventions that are being provided to the patient. This is one such assessment. It's called brief pain inventory, but this is not the complete assessment. This is only half of it. And this is another assessment, revised Edmonton's symptom assessment scale. As you can see that these are easy to fill in by the patients and they can be used frequently. And this, not to forget that there are specific tools that assess mental health, and this is to make sure that the comprehensive assessment is truly comprehensive and not focused on pain exclusively. These include tools like public health questionnaire to screen for depression and generalized anxiety disorder 7 to screen for anxiety. Invasive tests are best avoided. Even minimally invasive tests are carefully evaluated for benefit to burden ratio. The social needs of the patient should be assessed by asking relevant questions pertaining to important relationships in their life, financial burdens, caregiving needs, and access to medical care. Here are some of the questions you can ask to assess social needs. How often is there someone to feel close to? How has this illness been for your family? How has it affected your relationships? How much do you need help with things like getting meals and getting around? How much trouble do you have getting the medical care you need? You must address existential needs of the patient. The patient's emotional and existential well-being are assessed and should be determined whether the patient has found purpose or meaning. To assess this, you can ask questions like how much are you able to find meaning since your illness began, or what things are important to you at this stage. And this is one of the tools that you can assess to get a complete spiritual history. This is not the only tool that you can use, but it is a standardized assessment, so this can help. It is rather important for the physician to assess how the patient perceives his or her care. And you can do this by asking, how much do you feel your doctors and nurses respect you? How clear is the information from us about what to expect regarding your illness? How do you feel about medical care you are getting? Does it fit with your goals? Now, this is a very important step in providing the care, good quality care, and this involves communicating. This is one of the 7 step approaches that is used to deliver bad news. This acronym is P Spikes. It was introduced in 1992 by R. Buckman, and this is one of the most commonly used approaches. There are many other approaches that you can use. P Spikes involves preparation, which is to mentally prepare for interaction with patient and or family members. Second, setting of the interaction. You must ensure an appropriate setting with minimal disturbance for a potentially emotionally charged and serious conversation. Uh, a box of tissue always helps in this situation. Patient's perception and preparation. You have to establish the patient's and the caregiver's baseline of knowledge and determine if they can grasp information by frequently asking them how much they understand. Invitation and information needs is to determine what patient wants to or does not want to know. You must ask the patient how much of information they believe they want to know. And if they do not want to know the complete information about their illness, you must ask them who they can talk to about it. Knowledge of the condition, deliver information sensitively. You cannot just throw all the information at once. You must sensitively approach this matter. Empathize and explore emotions by asking open ended questions. Summarize and plan. This planning must not be hasted. You can wait and possibly put it on another visit because it must be too much for a patient and the family to handle at once. Let's move on to continuous goal assessment. This is a relatively new concept and that has been added to palliation. The difficulty in determining an accurate prognosis and the emotional resistance of patients and the families to accept the prognosis are major shortcomings in providing high quality care. This can be tackled by integration of care, as we talked about, that is, starting palliative care way before the final 6 months of life. Under this approach, the message of failure is no longer conveyed. That is, you still continue to provide curative treatment. That is, no more giving up hope. Goals that are frequently reassessed could include curing a specific disease, relieving a symptom, adapting to progressive disability, or even just finding peace of mind. Let's talk about advanced care planning. This is the process of planning for future medical care in case the patient becomes incapable of making medical decisions. This involves 2 types of documents: a living will, which are the patient's instructions about what to do in certain conditions, and designation of healthcare proxy. These are the steps you can take in planning of advanced care. First, you introduce the patient to this concept. Then you structure discussion of scenarios in patients with providing them real scenarios and some worksheets perhaps to let the patient know what to expect. Review their preferences, document the preferences, update the directive, and apply the directive. As of now, Massachusetts and Michigan are the only 2 states without living will legislation. In 26 states of United States, the law states that the living will is not valid if a woman is pregnant. All states but Alaska permit the patients to designate a proxy decision maker with authority to terminate life.
Please unlock your device first.
Let's talk about the interventions that you can use in hospice and palliative care. For to talk about it, we need to know what the common symptoms are in the terminally ill patients. The most common have been highlighted that you can address easily, that are pain, dyspnea, nausea and vomiting, constipation, depression, and delirium. I will not be going in much detail about the other symptoms, but since pain is the most common feature, so I'll briefly talk about it. You, what you use is called an analgesic ladder that has been proposed by the WHO. You start with the non-opioid medications or the mildest analgesics like acetaminophen, paracetamol, which is paracetamol, aspirin, or another NSAID, and you add an adjuvant if required. Then, if the pain is still not controlled, you move on to opioids like codeine, tramadol, etc., plus a non opioid, plus an adjuvant. And if these medications still don't help, you can move on to stronger opioids like morphine, fentanyl, and other medications. It is important to note that when you use opioids in patients for pain, you cannot use fiber supplements to treat constipation. You must rely on other uh, curative management or curative treatments for constipation. Make sure you address patients' social and existential needs, and this can include talking about the financial burden or relationships or any problems that they're facing. The final stages. When do you shift a person from palliative care to hospice? When at least two physicians decide that the time remaining for the patient to live is less than 6 months based on the mean survival, the patient can be shifted to hospice. It should be noted that hospice care is covered under Medicare Part A and it is 100% reimbursed. It can be provided at patient's own home or at hospice care home. There are four levels of hospice care home, including intermittent home care, where routine care is delivered through regularly scheduled visits by nurses, therapists, and other aides. Continuous care, which involves home nursing and which is provided for hours at a time and even overnight. This is used in case the caregivers are not available or need to go away for a certain period of time. Inpatient respite, the hospice provider checks a patient into a 24-hour personal care home that is staffed for hospice patients, or the general inpatient care if the patient has a medical need where inpatient treatment would be more appropriate. Uh, this is another there's controversy surrounding the for-profit and non-profit hospice care centers. The hospice care centers receive reimbursement per diem, which means that they receive money per day per person, regardless of the interventions they provide. Non-profit hospices are barely making their ends meet with limited margin for their budget and are being constantly compared to for-profit centers. And the for profit centers tend to house more patients with longer expected survival, for example, patients with dementia, and they do not even require many interventions to therefore they save cost and yet earn more than the non-profit hospice cares. Let's talk about withdrawal of life-sustaining measures. This involves stopping CPR, vasopressors, and transfusions. The most challenging aspect, however, is withdrawal of mechanical ventilation, which can be approached in two ways, that is, terminal extubation by removal of endotracheal tube, or terminal weaning, which is gradual reduction of FiO2 or ventilator rate. This is the preferred method by physicians because they believe that the patient does not um, have problems with asphyxiation or choking in the terminal weaning approach. But some physicians believe that terminally weaning can uh, prolong the ex- uh, tube in the can prolong the duration of tube that lies in the patient, and it can cause problems for the family members to bid their final goodbyes. Let's talk about Futile Care Act. Futile care is when a treatment will have no net physiological impact on patient's condition. States like Texas, Virginia, Maryland, and California have laws that provide safe harbor to physicians from liability if they refuse a request for life sustaining measures. This is an important topic which has many legislations currently going on, and physicians assisted suicide and euthanasia. It should be noted that termination of life sustaining measures and symptom management using opioids has been considered ethical for a long time, and it is not the same as physician assisted suicide or euthanasia. There are four methods that can be used to provide PAS or euthanasia, which are voluntary active euthanasia, in which intentional interventions are provided to cause death in patient with patient's informed consent. It is legal in Netherlands, Belgium, Luxembourg, Canada, and Colombia. Second is involuntary active euthanasia, which is the same as above but without patient's consent when the patient was competent to provide so. It is not legal in any part of the world. Third is passive euthanasia, which is withholding care from a patient to let them die, which is legal everywhere. And the final is physician assisted suicide. These are interventions by the physician to a patient with understanding that patient can use them to commit suicide. It is legal in Netherlands, Belgium, Luxembourg, Canada, Colombia, Switzerland, and states of United States like Oregon, Washington, Montana, Vermont, and California. In the United States, for physician assisted suicide, the criteria must be met, which is the patient must have a terminal illness with less than 6 months of prognosis, and the patient must be eligible through a process that includes a 15-day waiting period. When a physician is requested PAS or euthanasia, it must be clarified with empathic, open minded questions like what makes you want to consider this option? The patient must also be educated about alternative options. In the final days of the patient, the family members often have limited experience in what to expect. The healthcare providers must prepare them and explain how to care for the patient during this time. This has a comprehensive list of things that a patient goes through and what can be done to ease the pain or the problems. One of these examples is when the patient may be weak and fatigued and therefore unable to move, they may eventually develop bed sores. This is usually seen as a sign of giving up by the family. Physicians must explain to them that terminal fatigue will not respond to interventions and should not be resisted. An air mattress may be used to ease this. And this concludes the presentation. Here are the resources that you can check for yourself and find more information about palliative and hospice care. And thanks for paying attention. And November, that's the coming month, is the National Awareness Month for Palliative and Hospice Care. Thank you.